Pretty amazing, isn't it? To see it in black and white. I don't know about you, but I was taking pictures because it is over my head, and I gained so much from this. Coming up next is my cardiologist. I'm going to claim him because I have great care. Dr. Kevin Harris. He's a clinical cardiologist, echocardiographer at the Minneapolis Heart Institute. This is in clinical research and aortic disease and dissection. And he's also got a practice, and he writes many papers in discovery of prevention of disease to acute illness. No further ado, Dr. Kevin Harris, everyone. Want this out?
Thanks very much, Patty. I hope some of you that are traveling have been here at other times of the year when it's is a little different here. So if you haven't, please come back. And Diana, wonderful talk. And it really, I mean, she's the world's expert on this, the genetic diseases. So really tough for me to follow her, but I'll do my best. So what I'm going to talk about is what is an aneurysm. You know, people throw that term around. What does that mean? They start Googling it, and it is a little scary with the things you find, although there's a lot of good websites out there, as many of you know. So we'll talk about what is dilated, what do we constitute as dilation, how do we treat it, things that we don't want our patients with aortic disease to do, and you know, you guys are all advocates for your own disease, that's why you're here, but we want people to be aware of that when they visit the emergency room. And that was one of the themes of one of the Pulitzer Prize winning articles that Amy mentioned. And then what do we do when we take care of our patients after their dissection? So I read this book last year about Da Vinci, the biography, and it's actually interesting. He was actually the first to describe the currents in the aorta and describe the bicuspid valve and the differential flow, and he compared the flow in the aorta to the flow in a river. But he was characterized because he was immensely curious, and he seeked knowledge, and he didn't just take what was known, and he wanted to explore that. So I think by participating in this and other organizations, we can share our different backgrounds and really learn. And as Diana mentioned, there's a number of guidelines that we as the physicians base for our recommendations. She mentioned the American Heart, ACC, aortic guidelines from 2010. There's European guidelines. We have imaging guidelines. So we as doctors and then others that are not really immersed in the field go to these guidelines for really the information that they use to take care of their patients. And as Diana mentioned, I'm a member of the IRAD group. It was started by 3 individuals, Kim Eagle in Michigan, Christoph Nienaber, who's now in England, and then Eric Esselbacher at Mass General. And they put this organization together. So we share information and get together at the national meetings, share our patient data to better understand how to treat patients with aortic disease. So I don't know, can we play this? This is actually a nice example. It's a patient that had an ascending aortic aneurysm and then had a tear in the descending aorta, which I think you can appreciate right here. So when we talk about the aorta, there's the ascending aorta, which is the part right here, right above the aortic valve, or aortic root here, the ascending aorta, the arch, which is the transverse part, and then the descending aorta. So we'll be talking about primarily the ascending aorta. So what is an aneurysm? So when we use the word aortic dilation or aortic aneurysm, it's basically dilation of the blood vessel compared to a normal diameter. And a definition of an aneurysm typically is 50% bigger than the normal diameter. And as was mentioned, this is typically something that's asymptomatic. So in the past year, I've taken care of 2 patients that fortuitously saw us with 8-centimeter aortas. So they were very lucky that they just happened to get in to see us before there was a major problem. So at the present time, these, for the most part, are silent. Patients get imaging for some other reason, and the aneurysm is discovered, and the patient's fortunate. There's a lot of talk about screening. Who should be screened? Should athletes be screened, and are they different than other people? At the present time, that's not the standard of care, but there's a lot of community initiatives to do such things. So when we measure the aorta, and I'm an echocardiographer, but I work really closely with our CT and our MRI colleagues that are housed within cardiology at our place. But the report has to be really, really clear. So if we say to our patient, there's dilation of the aorta, I want it to be really clear that we're talking about the aortic root, or the ascending aorta, or which exact part. And when we report the aortic measurement, it's important that we measure it perpendicular to the flow of blood. So there's a lot of sort of mismeasurements because people are sloppy in the way they report it. It has to be reported in a clear and consistent measure, and it has to be compared to the prior measurement. So you can say, well, compared to last year, it's gotten bigger, it's not gotten bigger. And generally, we tend to prefer MRIs and echoes if we can because of the radiation. But the current CTs, really, there's not a lot of radiation there. It is important that we follow that over time. As far as measurements, too, there's clearly need for improvement. There's patients that have aortic enlargement on CT scans. The CT is done to look at something in the lung, and it's not mentioned. So that's something that I think we're better about, but I think we still have a long ways to go. So when I judge the size of the aorta, I judge it in relation to the patient's body size and their gender and their age. So just for example, and these, I use these diagrams just about every day. And this just happens to be one that we have for echo. And it looks at the ascending aorta size for men. There's separate diagrams for women. So for example, the sinus of Valsalva, or what the aortic root, that very first part of the aorta, and we have it as the patient is getting older, and then based on their body size, or BSA. And height is more important than the overall body size, but they're both important. So for example, if you have a 75-year-old man who has, let's say, a 4.2 centimeter aorta, that's really not that big because 95% of men are going to be between these lines here. But for a 20-year-old woman, that would be quite big. I'm not showing you that diagram, but that's how we judge where you are in comparison to your peers. Diana covered this far better than I could, but certainly a number of diseases that we consider when we're evaluating a patient with aortic enlargement. And when I see patients with aortic enlargement, we talk about their overall cardiovascular risk. So we address their blood pressure first. We strive to have that blood pressure well controlled, and infrequently it is not well controlled. We usually use beta blockers as our first line drug. The evidence is best in Marfan syndrome, but we extrapolate from Marfan's and treat most of our aortic aneurysms with a beta blocker if the patient can take it. We also use drugs called the ARBs, which would be like a losartan, and there's good evidence in Marfan. Again, we extrapolate to many of the other conditions and use those drugs, or the ACE inhibitors. We encourage the patients to not smoke, and we use statins. Usually there's another reason for the patient to be on a statin drug as well. But that's pretty much what I do as far as medicines. Now, what about athletes? So, there's this feeling out there that maybe athletes have bigger aortas. Well, really, that's not necessarily the case, maybe a little bit, but this is a nice study that came out that looked at the aortic size in the NBA players. So the NBA does echoes and stress echoes every year. So we have a lot of information on them. And so they put this together, and as you see in the NBA, all the aortas are less than 42 millimeters. So there's only so big of a aorta you can get if you're an athlete, and even if you're a big person. So this is a guideline I was invited to participate in, and it really goes through each of the sports and says what, or each of the conditions and what you are and are not allowed to do, depending on what your condition is and how big your aorta is. But generally, large sizes in the aortic size are not seen in aortas or in athletes. So, and then, another part of my spiel when I see a patient is I talk to them about what they do, and if they want to do weightlifting, we talk more about that. So, one of the surgeons from Yale has a nice series of 29 cases of aortic dissection in weightlifters. So, why that happens is with severe isometric stress, you can get this big increase in your blood pressure, which is tough on the aorta. We can also see this with mental stress in some cases, but a really nice resource for patients that are curious about this, written really for the post-dissection patients, but I think it's applicable to others, is this patient page, and you can find that online. And I can give you any of these references if anybody's interested. So Diana mentioned some of the surgical thresholds, and again, there's a lot of different things that go into that, which include how big the aorta is, obviously, that's number one. Is there a coexistent genetic syndrome? Does the patient have coexistent valve disease? Certainly, if the patient needs the valve done, then our threshold to intervene is going to be a little bit less. If the patient has rapid growth, but this is all in evolution, and I think there's not really one set number that we would use for a large man, for example, versus a smaller woman. So, and this is also important. So this is from our the IRAD database, looking at the aortic size at the time of a type A dissection. So these were patients. Well, they were in IRAD, so we weren't following them until they had their dissection. But if you look at it, most patients that had their dissection had a smaller aortic size than that 5.5 centimeters that is typically used as a surgical threshold. So it's somewhat humbling. On the flip side of that, I have a tremendous number of patients with 4.5 centimeters aortas that I follow. So there's many of those patients. We don't know the exact denominator in this population. And the rate of growth is very slow, and the risk goes up as the aortic size increases over time, but the rate that the aorta changes is really slow. One thing I'm not sure, and we can talk about this later, what to do with this information. Some of my patients have already heard this, but the FDA just came out with a warning against fluoroquinolones, which are antibiotics such as ciprofloxacin, cautioning the use in patients at risk for aortic problems with fluoroquinolones. I suspect we'll learn more about that. So in summary, for the thoracic aneurysms, we treat the blood pressure, not just the blood pressure when they come back to see me at the site where they had their aorta problem, but we want to get their home information, make sure their home cuff is working. We use those drugs. Everybody is told that they should not be smoking. I'm going to talk more about the acute symptoms. We talked to them about weightlifting. Diana covered the family screening, but that's obviously an important part of what we do. And then we do imaging generally at 6 months and then annually. So you've heard a little bit about Dr. DeBakey. That's one of the stories I like to say. But Dr. DeBakey said, no physician can diagnose a condition he never thinks about. So one of the efforts that Amy has done, and we've been doing on a smaller scale here in Minnesota, is making this on the radar for people. So they go into the local ER or clinic, people are thinking about it. And this is a series we just put together with the local cardiovascular pathology lab. And we looked at one of our internal medicine's residents, really helped and did a lot of work. But this basically shows the intimal tear, just like Diana said, this is the aortic valve. right above the aortic valve, there's a tear, and the reason the patient dies is they rupture their aorta, and that's the cause of death in about 60% of patients. So just a small tear in the aorta is all it needs for the patient to expire. But even in the current era of the cases in this registry, most of them are not recognized prior to their death. Just another close-up of the tear in the aorta. So if you tear your aorta, this is an emergency. So we've talked a little bit about type A dissection. So type A involves the ascending aorta, and this is days following presentation, mortality. So not everybody dies right away, but over time there's a significant mortality for the type B. So this is a more distal tear. Those patients tend to do pretty well, but with the advent of stents and such, we're treating more and more of those patients. But in IRAD, the mortality, this is a little bit older data, it's a little bit better now, but for the surgical mortality, patients coming to an IRAD center was 26%. For medical management, if they didn't get surgery, 58%. And when we looked at it, the dogma always was it's a 1% per hour mortality. And so we looked at this a couple years ago with the IRAD patients, and it still is 1% per hour. So these are all the patients hitting the hospital, and this is their mortality over 24 hours. So what we're doing is trying to work on getting the recognition of these patients sooner so they can get treated appropriately. So I've seen this presentation a few times, but the very first presentation or description of dissection was when King George II collapsed on his commode, and that was the first described dissection. And you've heard a little bit about Dr. DeBakey already. Again, the different types of dissection, the type A, the proximal dissections, these are the ones that need to go to surgery right away, and then the type B dissections, which start just beyond the subclavian artery. There tends to be a circadian variation peaking in the early morning hours, and also a seasonal variation. So, when a patient goes into the emergency room with chest pain, these are the conditions that whoever's seeing the patient needs to be thinking about and should trigger this patient could be having a dissection. So have they had a thoracic aneurysm? You guys are familiar with that. Family history of aortic aneurysm. And I think it's a good point about, whenever I'm talking to a patient, they're seeing me for their aneurysm or their dissection, we start getting into the family history. How many people have died of a heart attack, right? And I said, well, how do we really know is it heart attack, right? So that's something I think is deserves to be reinforced. Patients that have Marfan's syndrome or some of these other connective tissue diseases, aortic valve diseases, which Dr. Campbell is going to talk about next, or patients that have even had aortic manipulation, such as cardiac surgery. That's a significant number of patients that actually have dissection. So these are the conditions that should raise awareness for dissection. The patient with a dissection is a little bit different than the patient with a heart attack. And the best story I ever got, some of you have heard this story, but I was at a small academic medical center in New England, and as a second-year resident, this was in the era where the resident was the person in charge, and a patient came in, and it was a vascular surgeon, and his wife says, he's having an aortic dissection. And he was right. But usually, it's not that clear, Usually, there's a number of things that we have to go through, but that patient, who's a vascular surgeon, knew from the characteristic pain that he was having that there's something bad going on. So usually, patients will have severe pain. It's maximal in its onset. It can be tearing or ripping. I don't really hear those words quite as often, but the path of the dissection will dictate the symptoms. So if the dissection goes into the neck vessels, they may have jaw pain. If it goes into the abdominal aorta, they may present primarily with abdominal pain or leg pain. So there's a variety of different presentations, but some patients will just have syncope. They'll just pass out, or they might have heart failure. So it's a little bit of a tricky diagnosis. And then there's things on physical exam. When we listen to the heart, we can hear a heart murmur. That's important. That's present in about 2/3 of the people with the type A dissections. There might be differences in the blood pressure depending where the dissection path takes it, or the patient might be really sick. They might be in shock or have hypotension, low blood pressure. So there's a variety of presentations. But it's really tough for the emergency doctors because they are seeing a lot of people with chest pain, and really a very small number of those are going to have a dissection. But obviously, we don't want it to be missed. So we've spent a lot of time going around and sort of saying, as an adjunct to our heart attack program here, if you have if you have these features, we want you to be thinking about that. And we've gotten a number of our specialties together and coordinated the care for these patients. So we've traveled around Minnesota to all these little this is the one place I gave a talk, a little emergency room in one of the outlying communities. Met a few years ago, looking at, so this is again, IRAD centers, so time from the patient hits the door to the diagnosis is on average 4 hours. So if you go back to that 1% per hour mortality, you're going to lose four people right there, or 4 out of 100 people in that first 4 hours. And then from the operating room, or time from the emergency diagnosis to the OR is 4 more hours. And some of these are actually even longer than that. So the tests of choice, generally we don't do the transthoracic echo for the diagnosis. In almost all of our emergency rooms, the first test is a CAT scan. Rarely do we do transesophageal echo or MRI acutely. This is a transesophageal echo, and this shows you why the patient may have a murmur. So this is the ascending aorta here, flap prolapsing across the aortic valve, and then right there, the valve leaking. So the transesophageal echo can be used to make the diagnosis. Generally, we use that as part of our protocol when the patient gets in the operating room, just to save time, and that provides useful information for the surgeon. So what we've done is gone out and talked in many of these emergency rooms, efforts like this to raise awareness in the community. We have a specific way that we do the imaging. Amy brought up abdominal aorta scans. I don't know how many before we started this program where the patient was suspected of having dissection and somebody would get a scan of their abdomen, which doesn't really help us too much. Since we've had this algorithm, we see less of that. We still see it. There's a patient in the hospital right now that started with abdominal aorta scan. And we get the patients on the right medicines. A lot of times patients have a really high blood pressure immediately. We've worked on streamlining the transfer time, doing that transesophageal echo in the operating room. Then we have these algorithms which are in the electronic record, like a checklist, almost like the aviation industry of things that you want to do. Because it doesn't come up that often if you think of these outlying hospitals. So we have the protocols there for people. And it takes a lot of people too. So I'm a cardiologist, and I work very closely with these guys here, the cardiac surgeons. We have vascular surgeons, ER doctor, anesthesia. This is our nurse manager, imager, administrator, and then a statistician to help us look at the information and try to make sense of it. So we get together periodically and share cases and how the program is going, and even over the last couple of years, it's become a much more collaborative sort of effort with the vascular surgeons wanting and being involved even more acutely. So I think if we have time, I'm just going to show you a case. This is a patient from probably like 13 years ago now, right when we were starting. He's a 48-year-old man, no prior history, and he'd been having some chest pain. He went to his son's wrestling match and then nearly collapsed, and there was a doctor there tried to give him a nitroglycerin, which probably not the right thing to do in that setting, but he went into the local ER, and that was his CAT scan. And I talked to the emergency room doctor later, and his EKG was normal, and I said, well, why did you do this CT scan? And he said, well, he just kept saying there's something here. And so the patient was lucky. They they found this, this tear. This is the chest. This is the ascending aorta, which is dilated. And there's this is the, that intimal flap, and it extends around to the descending aorta. There's another flap, and there's a pleural effusion, some fluid in the lungs. So that patient was recognized in the emergency room, and they called the transfer service, and we brought him straight into the operating room and did the transesophageal echo. And 13 years later, he still comes to see me, and we see his family annually. Amy assured me this wouldn't be too much for you guys, but look away if it is. This is not this patient. I didn't say that. Trigger warning. The other Amy. Can we play this video? So this is actually a patient that sat in a different emergency room, again, with the patient had collapsed, and they called me, and the aorta on the echo had been like 5 centimeters, and the wall of the aorta was a little thick, and then finally they did this CT scan, which showed this, basically a contained rupture. It's not going to play? Okay, all right. Oh well. But that's a nice example of a patient that really had. It was a woman. She was very stable. She had sort of had this false lumen, and it was on the verge of rupturing, and fortunately it was discovered in time. And then this is what it looks like after the repair. This is the head over here, the heart's over here, and this is the graft in the ascending aorta. So, but anybody that's had a dissection is at risk for future enlargement. You can have development of aneurysms distal to the area that's been fixed. So we do feel it's important that the patients come back for annual imaging. We obviously want to keep track of their blood pressure and do genetic screening where appropriate, and family screening, talk to them about lifestyle and work restrictions. And this shows why that's important. So this is survival after a dissection. So this is years out. This is survival. And this first group are the ones that are coming back. These are the people that, for whatever reason, chose not to come back. So we believe coming back and seeing us makes a difference. So all of our emergency protocols are on an app. So we have that for physicians in our various outlying places. And another important part is this. So a number of efforts such as the John Ritter Foundation, the Marfan Foundation, the Aortic Dissection Awareness Day, and of course, Rock from the Heart.